Morning. We will now be studying the enterics, the organisms in our gastrointestinal tract. So this includes your Salmonella, Shigella, Campylobacter, and Helicobacters. So enterics, the family would be your Enterobacteriaceae. They have uh, the same characteristic. They share characteristics that they are all gram-negative organisms and gram-negative bacilli. And they contain their lipopolysaccharide in their envelope. So, of course, lipopolysaccharide is an endotoxin. Okay, they are associated with intestinal infections like your bacillarian dysentery, typhoid, and food poisoning. And they are facultatively anaerobes. They survive in the GIT. Okay, remember again, your facultative anaerobes are those organisms that usually thrive well in the absence of oxygen, but they can tolerate a small amount of oxygen. They are based, okay, their classification are based uh, on the presence of the antigen. The O antigen are the polysaccharide portions, the K or the capsular antigen, and your H or flagellar antigens. So endotoxin is a part because remember these are gram-negative organisms, so they will have endotoxins and it's a part of their lipopolysaccharides, which are produced by all Enterobacteriaceae. And this endotoxin is responsible for many of the diseases or the systemic manifestation of the infection of this organism. Some also will produce their exotoxins, so they are secreted from the capsules. Okay, they are caused by some species and strains, and this exotoxin produces diarrhea. Remember, your endotoxin produces systemic manifestation. Your exotoxin produces your diarrhea. They also have adhesins and fimbriae on some species, and they promote adhesions to the colon, to the bladder, and to other tissues. And the intercellular growth of especially your Shigella and Salmonella and Yersinia, the enteroinvasive E. coli, protects them from the host defenses. Remember, the we are we as hosts will defend ourselves. There will be cells where our macrophages, our neutrophils, and other macro WBCs that will tend to eat these organisms. They will try to engulf these organisms, but these organisms can thrive inside, okay, the one inside the cells that ate them. Your Shigella, Salmonella, Yersinia, and your E. coli, enterovasive E. coli. And this organism, unfortunately, will have uh, can easily develop antibiotic resistance because of the plasmids, and they can be transferred to other related bacteria. And the capsules, remember the capsules, so these are the encapsulated organism, your Klebsiella and Salmonella has the antiphagocytic property. So your Klebsiella pneumonia and Salmonella will have antiphagocytic capsules. So even if the macrophages will try to eat them, the neutrophils will eat them, but they cannot because they have they have their own defense. They cannot be eaten. And epidemiologically, your enterics are found worldwide, especially in the soil, in water, and vegetation. And they are part of the normal intestinal flora of animals and humans, so they can be excreted through the stools. Now, let's talk of specifics. Okay, we'll talk of your salmonella. It causes the condition called your salmonellosis. Okay. So, here again, because it's an enteric, so these are gram-negative, flagellated, facultatively anaerobe bacilli, and they have as mentioned earlier, they have their antiphagocytic capsules. And they have three major antigens in their capsules: their H, their O, and VI. Your H or flagellal antigen, your O or somatic antigen, and the VI antigen, which only few reservoirs has these antigens. So what are the virulence factors which are that your salmonella have? Okay, you have four. They have the ability to invade cells because of the VI antigen. They have a complete lipopolysaccharide coat, so they will produce a lot of endotoxin. They are antiphagocytic and they can survive if ever there will be chances that they will be engulfed. They have the ability to survive inside the macrophages and will be able to replicate intracellularly. And they do have some exotoxin because they can elaborate, okay, some toxins. Remember, your endotoxin will only be released once the capsule is destroyed. Okay, but the organism can excrete or secrete exotoxins. So this is a very nice graph or flow wherein how salmonella give us problems. Okay, first, so this is an oral fecal ingestion. So we ingest first. We will be ingesting the organism. Then the organism will be able to survive the gastric pH, and they will go down and colonize the lower intestine, particularly your ileum and cecum. And in there, they will invade the mucosa, will produce its cytotoxic enzymes, and it will induce acute inflammation, bearing ulcerations, glandin synthesis, productions of your enterotoxins, and production of cytokines. With all of this reaction, it will tend to increase and will activate your adenylyl cyclase and increase the levels of your cyclic AMP. And with the increase of your cyclic AMP, it will now trigger the excretion of fluids by your large intestinal bowel. There will be increased production of fluids and thereby producing diarrhea. Okay. So what are the clinical manifestations of salmonella? First is your gastroenteritis or food poisoning. Usually for Salmonella gastroenteritis, the symptoms usually begin 6 to 48 hours. Remember, your staph is less than 4, but for your Salmonella, it is 6 to 2 days after ingestion of the contaminated food. The manifestation of your food poisoning would be diarrhea, but it is also accompanied by nausea, vomiting, abdominal cramps, muscle pain, and headache, and with a low to high-grade fever of 38 to 39, and chills or rigors are common. The duration of your fever and diarrhea usually will be can reach up to 7 days, from 2 to 7 days, or 2 days to 1 week. The second stage of the infection would be your intermediate stage of infection. If ever you will not be able to control the clinical or the gastrointestinal phase, it can go inside our bloodstream and produce the condition of septicemia. In here, there is no intestinal symptoms, and bacteria cannot be isolated from fecal specimens. So, it may remain localized in the intestine or disseminate to the bloodstream. So they will tend to stay where? In the Peyer's patches. Okay. So, and later on with the with septicemia, with localization later on to advances to the bloodstream, it can now produce the more severe systemic form of your salmonella infection called your typhoid fever. So this is typhoid fever is one of the enteric fevers. This is the severe systemic form. It can be fatal. The best studied enteric fever is typhoid fever, and is usually caused by your Salmonella typhi. So it is usually preceded by gastroenteritis, may or may not. So we can have fever now from fever, anorexia, headache, and myalgias and constipation that they can be preceded by diarrhea. Incubation period of your typhoid fever is 10 to 14 days. So there are different typhoid fever is divided into primary bacteremic phase, which involves 7 to 10 days of incubation period, and wherein in the incubation period there will be invasion of the epithelium, that will be spread in the mesenteric lymph nodes and throughout the body. Okay, it's taken by your RAS or your reticular RES, reticular endothelial system cells. Okay, they usually can infect the liver, the spleen, the gallbladder, the bones, meninges. Okay, and they invade to via the thoracic bloodstream. So this one, that's why we will have later on inflamed Peyer's patches at 7 to 10 days. Then after the primary bacteremic phase, comes your second and heavier bacteremic phase. It usually will be a matter of 2 to 3 weeks post ingestion. So the organism will pass into the blood, and there will be onset of fever and other signs of clinical illness. And with the presence of the organism in the gallbladder, there will be further invasion of the intestine. The Peyer's patches and other gut lymphatic tissues becomes involved, and an inflammatory reaction ensues with the infiltration of your mononuclear cells and becomes your phagocytes. So in this second and heavy bacteremic phase, there will be necrosis, slowing, and formation of characteristic typhoid ulcers in the intestine and in the Peyer's patches. So for the onset, usually it begins 2 weeks as insidious, vague early symptoms. There will be a stepladder rise. So this is a characteristic, another salient feature of this disease is the stepladder rise of temperature from the first week of illness, which remains high. So your patient will be highly febrile for 7 to 9 days, then falls by rises during the third or fourth week. There will be physical signs like your bradycardia or decrease in your heart rate, which is not compatible with the height of fever. Remember, if you are febrile, you should have tachycardia. But for typhoid fever, you have fever, but yet you still have low cardiac rate. And you can now appreciate the enlargement of your spleen and liver. Okay, your hepatosplenomegaly. And often, if you are lucky, you can see rose spots in the abdomen. Okay, if ever there will be relapse, it tends to be shorter and milder. So what are the complications of your typhoid fever? They can be severe intestinal hemorrhages and intestinal perforations. So these are the fatal complications of your typhoid fever. So there can be carrier state for such conditions. You have carrier state for your typhoid. So the carrier will usually continue to excrete the organism for a year or more, the feces, and on further studies, the bacilli are mostly are present in the gallbladder, so it will be continuously excreted along with the bile and excreted in the stools. Okay, later on. So how do we diagnose typhoid fever? Blood culture and stool culture are a great mode of diagnosis. So since there will be presence of um, there will be the bacteremic phase. Okay, so the blood culture is the definitive diagnosis for enteric fever, commonly found during the 7 to 10 days and during relapse. So during the acute phase of the infection, you can have your blood culture. Okay, and during relapses, how about your stool and urine culture? In typhoid fever, stool culture usually positive from the second week, and urine cultures are positive on the third week. So, okay. So on the first week, it will be blood culture, which will be definite diagnosis. If ever you catch the patient late, do not expect to be positive in the blood culture unless it will be on a relapse. Then you can do your stool culture on the second week and your urine culture on the third week. Okay. Another crude and old test would be your Widal test. Okay. Your Widal test determines the presence of your antibodies. Okay. So when we are infected with typhoid, we usually fight back. We try to engulf the organisms. Our macrophages will try to engulf, and later on, we will be producing antibodies against the organism. And these antibodies are tested by, can be determined by your without the levels of your antibodies, okay, in the serum. So generally in typhoid cases, it is valuable that we know the specific titers. So how, when we will we say that it is positive, when the O antibodies is more than or greater than 80, or your age antibodies will be more than or equal to 160. So it is 80 antibodies, 80 or more, or in the H antibodies it will be 160 or more. In cases of paratyphoid fever, uh, the H antibody will be lower. We will require a lower levels. It will be 1 more than or equal to 1 is to 80 in paratyphoid fever. So if you're considering highly considering typhoid and the H antibody is only less than 160 but more or equal to 80, so we can be considering your paratyphoid fever. So how do we interpret your Widal test? So with other serological tests for acute infections, the usefulness of Widal test is greatest when we see fourfold or greater rise in the antibody levels. Remember, it's more than 80 for O or more than 160 for age. Okay, during the second testing of specimens. So initially you'll have your initial test, then you do your second test. Patient serum some days after the first time the diagnosis is being made. And there will be isolation of the organism from blood culture. So the detection of your VI antibody insignificant titer may be of limited value in the search for long-term carriers. So in search for long-term carriers, we cannot rely on the VI antibody even if in situations of outbreaks. So how do we control and treat typhoid fever? Fortunately, the disease has been with us for a while, and there are many doctors and scientists who tried and was trying and has been successful in developing vaccines for typhoid fever. So we usually give them whenever the child now is able to eat solid food, especially if they eat now communal foods or foods outside the homes. Okay, so some pediatricians give it at 2, but I usually give it at 1 because I've noticed that I've observed that children after 1 year old usually have almost adult type of gut. Their guts are mature and they are now exposed to food other than the food prepared at home. Okay, so they can be eating outside. So they can now give vaccines, but unfortunately, the vaccines are only partially effective. It's not 100%. No vaccine will ever give you 100% protection. Okay, so nevertheless, typhoid fever and enteric fever should always be treated with antibiotics so to control and treat and cure the infection and even to remove or treat carrier state. Now we go now to the second enteric, it's called your Shigella. These are the agents for your bacillary dysentery. So it's a gram-negative still. So these are gram-negative bacillus. They are non-motile. They are just like your Salmonella. They are facultatively anaerobe. They are non-spore forming, and they are closely related to the other enterics like your E. coli, Escherichia coli. So your Shigella is classified into four serogroups. Your four serogroups A, B, C, and D. Your A includes your some Shigella dysenteriae along with 12 serotypes, that's 12 serotypes. Your serogroup B includes your Shigella flexneri, which has 6 serotypes. Serogroup C includes your Shigella boydii, which has 18 serotypes, and D will be includes your Shigella sonnei, which has only one serotype. So this is the mechanism by which your Shigella produces infection or disease. Okay, again, just like your Salmonella, it is through oral fecal route, so the organism will be ingested and later on goes to the gastrointestinal tract and will produce disease as manifested by diarrhea, vomiting, okay, with dehydration, and usually we have tenesmus or severe cramping and relaxing of your intestine and colitis producing copious amount of mucus. Okay. Virulence of Shigella will are dependent on this toxins. Okay, your invasive, you have your endotoxin, which causes fever, shock, and bloody mucous stools and abdominal pain, um, uh, which are which presents as cramps and tenesmus, and of course, just like your salmonella, it has an exotoxin called your Shiga toxins or your vegotoxins, and this Shiga toxins is a neurotoxin, and it kills intestinal mucosa. It's an enterotoxic and cytotoxic toxin, and can this one will make the it presents as diarrhea, the presence of your exotoxin. Okay, while your endotoxin produces fever, shock, and bloody mucus stools and abdominal cramp, not diarrhea. Okay, but your exotoxin, your Shiga toxin, produces diarrhea. So how do we diagnose? Aside from the clinical manifestation, you can do cultures from the stools, your blood tinged uh, mucus stools, and you can also do your rectal swabs. Okay, and we can do serological testing like your slide agglutination test with anti-sera for serogroups and serotype will confirm the identification. We can do your PCRs or your polymerase chain reactions, and also we can do your ELISA or your enzyme link immunosorbent assay. So again, because it is through ingestion, so it occurs by fecal oral contact. Remember, you're eating the poop of other people. Okay, that's how easy you can remember. It's fecal oral contact. It can be transmitted by an infected adult through food. Okay, especially those who are infected and later on are preparing food or who does not uh, practice sanitation. And remember, for Shigella, man is the only reservoir. So how do we treat? Okay, whenever you have Shigella infection that will manifest as diarrhea, so of course, for all diarrhea, the number one consideration or the mode of management is to prevent and manage dehydration. So that would be our primary concern. And those patients presenting with severe dysentery, they are treated with a very cheap antibiotics. It's your ampicillin. Now we're very fortunate that these are organisms that don't require expensive ones. Okay, patient response to antibiotic therapy and disease duration is diminished. Next, among the enterics will be your Campylobacter jejuni. So your Campylobacter jejuni are gram-negative, oxidase-positive, and causes okay, profuse or watery or bloody diarrhea. And they can manifest as pus in the stools with cramps and fever, and they can produce ulceration on the mucosal surface of the jejunum and colon. Okay, and this organism is very infective. Okay, so for Campylobacter jejuni, infection is commonly acquired by ingestion of contaminated food, especially your poultry and milk or even water. There are asymptomatic human carriers, and our lethal paths are your animal reservoir for the spread of your Campylobacter jejuni. The incidence of your Campylobacter jejuni peaks in young adults. In cases of decreased acidity of your stomach, like lack of gastric acid and hypogammaglobulinemia, will increase the risk for acquiring your Campylobacter jejuni infection, and it also will uh, be okay. Uh, it can affect the severity of the disease. Okay. How do we treat Campylobacter jejuni? First, because it manifests as diarrhea, we do symptomatic treatment, treat and manage dehydration. And we can treat now. So your Shigella can be treated with ampicillin, but with your Campylobacter jejuni, we can treat it with your quinolones, okay, and fluoroquinolones. Okay. Next will be your Helicobacter pylori. These are like uh, creatures from outer space. And maybe this is the basis of the alien thing that usually are seen in the movies or in TV series. Okay? They are like aliens. Okay? So these are gram-negative, oxidase positive, urease positive, and catalase positive. So they have a lot of enzymes. Okay? Oxidase, urease, and catalase. They have, you see, obviously they have highly motile rods. Okay, and they are carb rod with multiple flagella. So the virulence of your Helicobacter pylori will be dependent on the neutralization of your local stomach acid by urea. So it induces decrease in the pH, increase in the pH, neutralization of your local acid because of your urease, which produce ammonia, and with this one it promotes initial colonization. There will be rapid penetration of your gastric mucus, and the mucus barrier is facilitated by multiple flagella, so you can burrow through, and in turn there will be signs of local tissue damage by mucinase, and cytotoxin will stimulate the infiltration of your inflammatory cells. So with this chronic infection of your Helicobacter pylori, it can increase the risk of developing low-grade gastric malignant lymphoma. And the increase in secretion of gastrin and gastric acids stimulated by infection will promote metaplasia and also will increase the risk of developing gastric cancer. So there are two malignancies that are produced: low-grade gastric malignant lymphoma because of your mucinase and cytotoxin, and the development of your gastric cancer by your uh, gastrin. Okay. So what are the diseases caused by your H. pylori? Okay. The most common cause, your H. pylori is the most common cause of stomach and duodenal ulcers. It causes chronic atrophic gastritis of the pylorus and antrum with possible progression to gastric adenocarcinoma and also low-grade malignant lymphoma. Okay. So how do we identify? What are the tests that can be used to identify your Helicobacter pylori? Now, you can have your CLO test, your Campylobacter-like organism test, which detects urease in gastric biopsy. So you'll have your endoscopic exam to look at your gastric mucosa, and they usually take a biopsy, and you can be tested of your CLO. Your CLO is 95% sensitive and specific. Or you can do your blood test, your serologic test. Okay. However, your serologic test will remain positive over a long period of time. So, because of this characteristic, it limits now the usefulness for the detection of recurrences and even limits the usefulness of determination of treatment success. Another excellent test would be your radio-labeled urea blood test, which has excellent sensitivity and specificity. You can also have the cheapest test would be your stool antigen test. Though it's the cheapest, it also offers excellent sensitivity and specificity, and it is very good in determining active disease and excellent in detection of treatment success. So all in all, your stool antigen test can be preferred because it is cheap, has high sensitivity and specificity. You can detect active disease, and it can now assess the treatment success. For Helicobacter pylori, your stool antigen test and your blood test are very good in detecting the presence of H. pylori in the stomach. Your enzyme-linked immunosorbent assay is used to determine seropositivity. How do we transmit? So it is transmitted by ingestion or sanitation and person-to-person transmission. The prevalence of infection is relatively low during childhood, but rises relatively as we grow old to almost half, okay, of the adults, around 40 to 50. So how do we treat? So the treatment is quite expensive. Now, I know the treatment for Helicobacter pylori is quite expensive, but because it entails many drugs, triple drug therapy, which are given 2 weeks, okay, or continuously for 2 weeks. So these are the combinations. Okay. So you can have your bismuth salt with metro and amox. You can have your bismuth salts with your ranitidine and claritro. You can have your proton pump inhibitors, like example will be your omeprazole with amox and claritro. So that's it. So it's better not to acquire Helicobacter pylori or even your Campylobacter jejuni, or even later on with your Salmonella and even your Shigella. If you have vaccinations for your Salmonella, you prepare your food, eat in places where you know, at least partially, you can assess that it's clean. So you better be careful in eating street foods, okay? In foods that you didn't see how it was prepared, okay? So Prevention is better than cure, so vaccinate yourself with typhoid. So though it may not be that effective, may offer partial protection, usually given every 5 years in highly endemic areas. Okay, so that's it. So that's my lecture for the enterics here: Salmonella, Shigella, Campylobacter, and Enterobacters. Okay, and Campylobacter, Virginia, and Helicobacter. So see you again on my next session. See you next week. Maraming salamat po. Study well. See you next study session.